In this presentation, I'm going to be looking at what is required of you from your case logbook. It's important to realize at this point that it doesn't matter how well you place your implants and how well the case turns out. If your logbook is missing or doesn't have all the clinical pictures and radiographs required, then it can't be assessed by the institution awarding the license. So it's most important that you spend time on the case logbook. Ultimately, if any information is missing or lacking from the case logbook, this is entirely your responsibility. And also, if you don't have the records associated with the case, that does draw into question your ability to manage implant cases in terms of record keeping. Okay, so to begin with, you're going to send a ticket. This may be regarding a case you've been allocated as an intern, or maybe a case from your own practice. When you raise the ticket, it's most important that you give the reviewer or your tutor some information. Don't just send a few pictures and a radiograph and expect them to be able to guess what your intentions are. Always remember to give a brief outline of the patient's general health, and then follow this up by what you intend to do for them generally in terms of fillings and periodontal treatment or scalings and hygiene instruction, and then explain where you intend to place the implants, if there's going to be any extractions needed, the type of placement protocol, and the number of implants. Now, it doesn't matter if subsequently this all gets changed. This is just a preliminary overview of the case and initial case discussion. Once you've raised the ticket, you'll be able to attach and send pictures. Now again, the x-rays must be of really good quality. They shouldn't be pictures off the screen of radiographs. They should be the actual JPEG files. It is all right in the early stages to use your mobile cameras, and if there's some fuzziness there, that doesn't quite matter, because you're most likely not going to be using these pictures in your actual case submission. But later on, you will need very good, clear, high quality images. So what should your clinical case logbook look like? Well, it's basically a record of important events in the management and delivery of your treatment to your patients. It's a diary of what you did. And it's essential that all the treatment steps are very clearly and fully recorded and documented. And this is helped tremendously by having very good, clear radiographs and clinical pictures of the highest quality. What should the logbook demonstrate? Well, the emphasis on the quality of patient care rather than the quantity or complexity of implant treatment. Many of you think it's about doing sinus lifts or advanced graft procedures. This is not the purpose of your internship, and it's not the purpose of your license. Your license is reflecting your competency to plan and treat implant cases within the scope of your skills. If you start doing sinus lifts and graft cases, the question's going to be asked, where did you get your surgical training? Are you a consultant oral surgeon? Because these are skills and abilities outside the scope of a usual general practitioner. So again, complexity of case is not necessarily going to win you any points at all. What they want to see is competency in your treatment planning, and they need to see whole patient care. It's no point having a wonderful implant restoration placed in a periodontally diseased mouth, because ultimately those implants will fail through peri-implant disease, and you haven't met an essential requirement of osseointegration in that the interface remains healthy. Also, the occlusion should be stable. Again, implants are very vulnerably long-term to poor occlusion and occlusal overload. And it's important in your logbook that you show that you have considered the occlusion in the treatment planning stage, and that you've taken steps to ensure that it's stable. Now, when you come to uploading and registering your case, there are sections that you need to fill in. And the first section that you need to do is general basic dentistry. That is the patient's medical history, their periodontal examination, the BPE, and of course if they get a 3 or a 4, you should provide a whole charting. An occlusal analysis, if the patient's any pain, the details, a soft tissue examination, and of course a dental chart. All of this is box filling. As regards the dental chart, there is additional videos on this topic. But you can start to fill this in even before your patient attends the clinic. Remember, try and get as much as you can done as you go along. Do not leave everything to the last moment, because you may find you've overlooked some piece of information or don't have the data to hand. Now, the next important part of your case log is the contemporaneous notes. Now, what we need to see here is notes about the patient's treatment. Contemporaneous means notes recorded at the time. So we need to know what treatment was carried out to make the patient fit before implants were placed, what consultations were carried out, and these all have to be dated. It's not sufficient to just put a date and say tooth extracted, implant placed. That is not contemporaneous notes, and if you do this, then there's a likelihood the case may be rejected by the reviewer. Also, in the current situation, under the consent section, you need to put in what the patient's presenting situation was. So, for example, they presented with gross periodontal disease, poor oral hygiene, multiple broken teeth, whatever the situation was when they came to the surgery, and what their requirements were. For example, you may put that the patient only wished to pay for one implant because that's all they could afford. And so your treatment plan has been geared to do this, and that you are going to be doing root planing or whatever it is that you intend to do to the remaining teeth. So that's the current situation. Then you have your proposed treatment. Now this is your treatment plan. This is how many implants you intend to place, where you intend to place them, the protocol, if there's any additional procedures attached to the implant placement. This is where you're going to itemize the stages of your treatment so that the reviewer knows exactly what you intend to do. Now, the most important part of the locker box is your image albums, and you'll have albums there for study models, radiographs, clinical pictures. First of all, the pictures must be as clear as possible. There's no point having poor quality pictures. And attached to these pictures must be a full description of what you're intending to show by the picture. For example, what the biotype is, what the ridge type is, if there's recession, if there's abrasion, if there's fillings defective, whatever the picture shows you have to describe in detail. Again, it is not sufficient to put picture of patient smiling or front tooth or left buccal quadrant. That is not what is required. You need to have a proper description of what it is the picture is showing. So it might be that it's a narrow ridge or a defective composite filling, something of that nature. Finally, we come to the implant data section. This is where you will enter information about the type and the length and diameter of the implant used, together with the batch number, together with anything to do with the bone quality, or if a membrane or localized graft was carried out. So this has all the information related to the implant, and this should be backed up again in the contemporaneous notes. So as well as saying I placed the implant in the upper left central region and I placed a graft material, this should also be recorded in more detail in the implant data section. Failure to do this again will leave your log open to question and possible rejection and failure. Now, it's most important, as I've said, to have good case images. And ideally you should have full mouth photographs to include upper and lower mirror views of the arches, right and left views showing the teeth in occlusion, anterior views showing smile line and the clinical crowns, and any other pictures you may consider show certain points. Take as many pictures as you can. You cannot take enough pictures. Radiographs. Now, students must not just solely rely on OPG radiographs. It's important at some point to have a PA radiograph to show the bone level. OPGs will not show bone level accurately around single implants or even multiple implants. So when the implant has been restored, you will need to take a periapical radiograph to show the bone level. Then some 6 months later that radiograph should be repeated so that you can show the bone level is remaining stable under function and isn't being lost. And as you know, that's a requirement of osseointegration, is that it should be a load carrying implant, and you won't be able to demonstrate this unless you have periapical radiographs. Now at some point you will all be coming in contact with CBCTs, and you may actually plan one of your cases using a CBCT. Obviously the site cannot manage a complete scan. What you will do is you will take screenshots of the appropriate sections of the CBCT, and your tutors will help you with this. We also want to see pictures of the study models mounted, and also pictures of the analog models and pictures of the restoration or framework on the analog models, so that you can show that the restoration was fully fitted and correctly designed. Again, once the job has been fitted, it will be impossible to go back and take pictures. Now I'm going to show you a selection of pictures that have been taken and presented as part of students who are taking the MSc, so that you realise that this is quite a common problem and one which needs to be redressed fairly early on in the process. Now occasionally it may be necessary to take a patient's full face. If you do decide to do this, remember to block out their eyes. But in this particular picture, the patient's head has been chopped off. In fact, he's been given a frontal lobotomy. The picture isn't properly centered, and so it's very doubtful that this picture is of any clinical relevance. And again, you should not be uploading this standard of picture to the site. Look at this picture of the patient's oral cavity. It's far too distant for me to be able to make out any detail regarding those teeth. The lips are distorted. The patient seems to be at an angle. His nose is in the picture. His chin's in the picture. There's all sorts of distractions going on, and even equal or balanced retractors haven't been used, which makes the thing look very odd, but also again calls into question the professionalism of the dentist taking the pictures and the quality of the work and the care of attention that they give to their dentistry. So what needs to happen is the patient needs to have a close-up view of their mouth. And here we can see the same patient, and we're beginning to see a lot more detail. In fact, there appears to be some scarring. If you look in the above the upper central incisors, you can see some scarring in the buccal mucosa, indicative of some periapical surgery. Possible gum recession on the upper right central. The upper right canine appears twisted. All sorts of information now can be determined about this case. I can see that this case is a biotype 2. It has a normal bioform, good papillary infill. There's all this kind of additional information, and all of this should be noted down when you come to narrate and label the photograph that you've taken. The occlusion seems to be intact. although there is a little bit of a run. So these are all points that you should be making from the photograph, which you wouldn't have been able to make from the previous photograph because it was just too far out and too distracting and not showing all the information required. This is a completely overexposed picture and is completely pointless and worthless. It shows no detail, but the student uploaded it because it was the only picture they had available. Now this is not an excuse and really reflects quite badly on the student and on the standard of their practice, because if they're prepared to accept a whitewashed picture, maybe they're prepared to accept a poor quality radiograph when it comes to planning and positioning their implants. This was uploaded because the student forgot to take a picture but wanted to put some narration in there, so he explained that it was of a central incisor with that was biotype 1 with gingival recession. However, he didn't have the picture, so he uploaded a blank so that he would have something in his log. Again, this does not really show any level of professionalism and would call into question the whole quality of the treatment provided. This again is a very poor quality picture. There should be retractors in both sides of the mouth. I can't see any detail to do with the edentulous area because of the way the lip is falling. And again, the picture is very distracting and not at all clear. This is a picture of a restoration or trying in a framework, and again it's very difficult to see what is happening. The picture is at an angle, the patient seems to be looking slightly upwards. I can't see any detail. But if we crop in and we level the picture out, I can now see the occlusal plane. I can see there is quite a bit of occlusal wear. I can see the amalgam filling is showing signs of wear. I can see the fit of the framework to the metal abutments and the quality of the margins and what is being intended and planned for this patient. This picture has been taken of the patient's lips. The problem here is, again, it's not focused in on the patient's lips. It's showing an awful lot of skin of the chin, and the nose is visible, and it's not even possible to decide whether the slope that I'm seeing on those teeth is due to the way the camera was being held or that there's an actual run on the teeth themselves. It's just not clear from the picture what the situation is. It could well be the patient has asymmetry and the right hand corner of the lips or mouth embrasure is higher on the right than on the left. There may be a slope like that, but it's just not possible to tell from this type of picture. Again, we have a picture showing all sorts of things. I'm not sure whether I'm supposed to be looking at the labial surfaces of the teeth or the palatal surfaces of the teeth. What is the area I'm supposed to be looking at in this picture? This I call the Picasso, the abstract, because it shows all kinds of things. I can see the upper teeth, I can see perhaps the lower teeth, I can see fingers in the way, I can see retractors, and even worse, the fingers aren't gloved. So it makes you think cross-infection control, poor quality of hygiene, all sorts of things run through your head, and one has to wonder what the point of this picture is. Again, we have a picture showing not the entire arch. It's a mirror view. It doesn't show all the arch. It's at an angle. It's not clear, and one has to question the standard of the clinician and the work they provide when you see pictures like this. Here we can see an operative picture. Again, it should be zoomed in. I can't see the area that the surgery is taking place very clearly. When you look at the slides in our presentation, you will notice that they're zoomed in on the area and you can quite clearly see what is happening. In this situation, I can't make out anything. I can't read the scale on the instrument. I don't know if it's gone into an extraction socket or what is happening. I can see the patient's nose, upper lip. I have no idea if this is relevant to the treatment. Most likely it is not. Again, this kind of image does not bode well for the quality of the case log. Now in this case we can see a model, an analog model. The model itself is nicely in focus, but the hand in the background is a distraction. Now this is what I call the gift box set of teeth. The dentist hasn't bothered to remove the restoration from the box. Now this again just shows laziness and can't be bothered to position and take a decent picture, and again makes you question the competency of the dentist presenting the case. In this situation, the box hasn't even been opened and the picture has been shot through the cellophane wrapping. Again, any detail on this restoration is obscured by the cellophane, and again it makes the examiner and the reviewer of the case file feel that the quality of the work may be in question, even if this is unfair and the work was done really to the top standard. The fact that the case log is so poorly photographed and presented makes one feel the whole case, the clinical case, is exactly the same, because the case log reflects the quality of the treatment provided. If the case log has poor quality pictures and isn't well thought out, then the inference is that the entire case is badly thought out and badly planned, which is not the purpose of your case log. Now this picture, the restoration has at least been taken out of the box from the laboratory. However, it's been taken at such a long way away that no detail of the restoration can be seen, so it's like you're looking at a Google map from space. Now in this picture, the mirror has been allowed to frost up, and pictures like this again are of no real clinical use or relevance. It may make the tooth look very romantic, but it obscures all the detail. And again, as I reiterate, these kind of pictures do not show a quality log. This picture, there's more staining on the mirror than there is on the teeth. Again, this shows very sloppy work, very poor attention to detail, and maybe even draws into question infection control. So you can see that a well-planned case, maybe a well-executed case surgically, is completely ruined by this picture. In this situation, I'm not sure whether I'm supposed to be looking at the patient's teeth or at their hairstyle and comment on the quality of the dyeing that's been carried out. Again, the picture should have been properly centered and should have been zoomed up to show the area of relevance, and mouth retractors should have been used, unless of course it was to show the smile line. This picture is again completely useless. The framework is out of focus and I can't see the fit. I can't see if there's any soft tissue on this model, and the student who presented this again said it was the only picture they had. So one has to ask why, with modern day photography and autofocus, one can't take more than one picture, especially when it's so essential to presenting your case log. Another soft focus, and we can't make out the teeth. It looks like the camera was focusing on the molar teeth on the other side of the arch so that the restoration was completely out of focus. And once again, I reiterate, this kind of picture is really unacceptable and just demonstrates poor attention to detail and reflects badly on your standard of clinical workmanship. When you're taking pictures, always ensure that you use retractors. Seeing fingers or mirrors retracting lips does not look good. If you think back to symposiums that you attend, how many of them have the operator's fingers, gloved or otherwise, in them? So always use retractors. If you haven't got any retractors in your practice, then please purchase them. They're not that expensive. Also, the mirror again is steaming up. We now have a completely out of focus in that we cannot even identify what we're looking at, and so I've called this the unidentified flying object. Finally, when you're placing a restoration, obviously you're going to check the occlusion and you're going to use occlusal indicating paper, and that's perfectly acceptable. However, please remember to remove the indicating blues and reds from the teeth, because again it detracts from the image and it just doesn't look very nice, and you want to present your case in the best possible light possible. Of course, if you're trying to demonstrate high contact and explain this in the narration or the labeling of the picture, then that is completely acceptable. Now, this picture is an attempt to try and show the size of a space. This is quite a useful way of showing a space, but do not use your fingers to try and get across how large the space is. If you want to show the extent of a defect, then use a probe or perhaps use a small ruler, but do not use your fingers. Here we have a very clear radiograph. It shows a certain amount of pathology going on, shows anatomical structures like the ID nerves and the sinuses, and is a reasonable OPG. Now, the point here is that it's important that when you have the radiograph that you carry out a full and proper radiographic report. Here is the radiographic report for that particular OPG, and you can see it outlines which teeth are missing, where there's restorations, where there's existing, where there needs to be fillings done, that there's infection. All this information is recorded in your radiographic report. You will also see that next to radiographs there's a score or grade, and that grade is from 1 to 3. 1 is excellent, 2 is acceptable, and 3 is diagnostically unacceptable and of no use at all. Obviously on this program we don't expect to see any grade 3 radiographs going on the site, because these are of no relevance and no use to demonstrating the case, and actually would be detrimental to your presentation. So remember, you have to do a detailed report of the radiograph. If you don't, then during cross-examination of your cases, somebody may well ask you what you intended to do about the pathology on the lower right 6, and if you've forgotten all about it at that time, it can look like you might have missed it altogether or ignored it. Either way, it calls into question your competency, so please mention it in the radiographic report, and then you can refer to it, and it's very clear that you're aware of the pathology, and also it should be very clear how you intend to treat it, and when you present the final restoration, the pathology on that tooth should have been resolved. Also, it's important to take your initial x-ray or follow-up x-rays with a periapical radiograph. This particular radiograph shows perhaps some bone loss associated with the implant, which we don't really want to see. But also, quite interestingly, if you look at the canine position, there seems to be something strange going on with the root, and there seems to be a cyst forming around that area. So again, pathology going on in that area, which should have been dealt with before the implant was placed. Again, we can see an implant placed close to a root-filled tooth, and again we can see pathology from the root-filled tooth associated with the implant. Now, we'll be discussing this kind of thing in more detail when we look at root canals and implant treatment, but of course this is not the kind of thing you want to be presenting in your completed cases. So if we're going to be placing implants next to root treated teeth, then to begin with you should have good quality PA radiographs of the root treated teeth. Do not rely on an OPG, because an OPG may not show the pathology. And then later on, when you come to take the PA to demonstrate that the implant has been in function for 6 months, you then discover there's a load of pathology around a root treated tooth. And of course that case is unusable. Contemporaneous notes, as I've said, as you go along and you do treatments, write full and detailed notes. Do not write small sentences. Again, if you do this, you leave yourself opening for questioning why weren't the notes complete, or if you then later on somebody asks you a question about a certain treatment and you try to explain yourself, if it's not written in the notes, it looks like you're making excuses, or maybe you never did it in the first place. So this is an example of contemporaneous notes. There's a lot of detail in those notes, an awful lot going on in those records. So if we look at our evidence-based dentistry, the Cochrane collaboration and bodies such as the National Institute for Clinical Excellence, NICE in the UK, they said that evidence based on issues such as the quality of clinical record keeping, selection criteria for dental radiographs, antimicrobial prescribing in dental patients was all an indication of the quality of the treatment the patients received. So a lot of the time, if you have poor quality records, if your radiographs are poor, if your pictures are poor, it is evidence of poor standard of dentistry, and this is what we do not want to be seeing in your case logs. So you have to consider, is this informed consent? This does not look like any kind of proper treatment planning has gone into it. It's a brochure from an implant company, and this is the kind of thing we would not want to see uploaded into the documents section of your case logs or used as a treatment plan. You can see he's put 2 to 3 times implants, and he's put a cost there. He's put a post and he's put a cost there. So there's lots of financial information, but there's no clinical information whatsoever going on in this treatment plan. Look at the quality of these models. They're not shown in occlusion. If you want to show the models, you should take a picture separately of the upper arch and a picture separately of the lower arch. Both of them stuck together on this hinge articulator, again, is not evidence of quality or any form of assessing the occlusion. This particular model had the teeth broken off. Now, this does happen, but you should not be taking pictures for your clinical log of models with broken teeth. Again, it just does not look very high quality. It looks like poor standard of treatment and patient care. Here we have the models in articulation, and we can see the broken teeth just above it, and again, this does not look like any kind of professional care is being provided. This shows the models in articulation, but just look at the quality of the models. There's lots of air blows, there's bubbles all over the place. If you were trying to assess the occlusion, how can you assess the occlusion when you've got bubbles and plaster nodules on the occlusal surface? How can you occlude that? How does that show any form of quality of treatment? Could anybody make any kind of diagnostic decision based on that model? And the person who's reviewing it, what sort of decision can they come to based on what they're seeing in that model? Would this make you think the practitioner was working to a high standard of care, or would you perhaps feel they weren't? This is a radiograph. Now, I've said before, do not take pictures of radiographs on scanners or viewers. Get the original JPEG file. The pictures of our provided patients, you'll be given the actual JPEG file, but if you're doing pictures in your own practice, again, make sure you get the actual JPEG file. This is a picture taken off of the scanner, and the diagnostic quality is 0. This would be a grade 3, completely useless, and in fact presenting this in your log would not bode well for you or the quality of the treatment you're providing. This again shows, I do not know, there seems to be some apical pathology, but I don't know what kind of tooth it is. I would be guessing. I don't even know if this is left or right. There's no dates associated with these radiographs. So again, completely useless, and these have been presented as part of case logs. Now, what is the role of your clinical supervisor? Well, they're to offer you mentored supervision during your clinical cases. They guide the interns through the assessment and treatment planning stages of their implant case. They offer support and guidance on developing your portfolio of evidence, which is the collection of your clinical logs. They will help you to present these in the best possible way. Now, they are not there to check that the documents are complete. They're not there to provide images of study models or to write your case reports for you. You are entirely responsible for ensuring the quality of the pictures and ensuring that all the pictures necessary are there from the start. This is not the responsibility of your clinical supervisor. If you are missing any pictures or the pictures are of poor quality, then this is entirely down to you and not the supervisor. Also, if your case is eventually rejected on the grounds that it's not complete or that it's poorly written or presented, again, this is your case report. It is not the role of your clinical supervisor to do your case log for you. This is entirely your responsibility. The role of the supervisor is to ensure that you treat your patients safely and competently, and that you get restorations which are stable and osseointegrated. However, your role is to write your case log and to ensure the material is all present for you to be able to write this log. Many students on courses may well do all the implant cases, but at the end of the day still do not achieve their goal of a license because they just haven't collected and assembled the data necessary. We will help you to collect this data. We will support you in the collection of the data, but you need to identify what data is missing. You need to upload it regularly to your cases and make sure that they keep on track. Now, as you go along, you will be given cases. However, we will be monitoring the cases, and if we feel that you're not entering the data or keeping up with the cases, we will not give you more cases on the course till you have completed entering all the data that's necessary. Obviously, if the data's not there or the radiograph's not there, you can't be expected to enter what is not there. However, If the information is there, you need to have uploaded it and you need to be keeping on target so that when you've completed all your cases, they're all ready to go. There's no delays in writing cases up. So at the end of the day, why bother having a case log in the first place? Well, without a complete documented record of your training experience, you cannot be assessed externally or audited by a university or licensing authority. It's impossible for them to be able to know whether you're competent enough to be given a license to be able to place implants. And if your documentation or your case is incomplete, then this will not be proof of any kind of competency and of good management skills. In fact, it will go to show exactly the opposite. So you need a really good portfolio of treated cases to be able to present to show the levels of surgical skills and treatment planning skills that you possess. If you don't have this evidence to hand, then nobody will know how good you are. So, if we reflect now on the purpose of this presentation, it's to highlight that poor quality pictures and records will not convince your assessor or your licensing body or colleagues that you are competent to place implants. In fact, it will do exactly the opposite. Also, that the onus and the responsibility for ensuring you have good quality pictures and x-rays and that it is all correctly uploaded and written up, that rests entirely with you. It is your case log. It is nobody else's case log. We on the course will help you in all ways possible to get the data required and will advise you as you go along on how your log is proceeding. But at the end of the day, it is your responsibility to see that all the data is uploaded, and you should be doing this on a regular basis, not in bursts of activity, because if you try to leave it till the end, you'll be writing up multiple cases. Some of you have to present 30 cases, and to try and do this in one go at the end of several years is a tremendous amount of work, and also you are likely to miss information or present poor quality case logs, which would be a great shame if you've gone to all the trouble to ensure that you provided the best possible treatment to your patients.